Yeah, endometriosis is a serious challenge to a lot of women. Apart from the pain it causes to them, it affects the family, affects the woman's lifestyle and well-being. And of course, it's a major contributor to infertility. And it's the presence of endometrial tissues in other places apart from the endometrium, uterine cavity. So it's a big problem everywhere. Apparently appears to be more common even in Africa, so more widespread than even in a more developed nation. So the need for skills in doing endometriosis surgery is very high in the continent, and Dr. Joe is a known figure when it comes to endometriosis surgery. It's so needed everywhere. Unfortunately, most governments pay lip service to health in general. It's a very big need if women's health have to be protected. So the government needs to invest in it, not only in Kenya, the government in even my own country, where many people have to depend on government, the NHIS to access care. So they need to invest in, people are using the robotic surgery to even do the surgeries. So we need to get to that point so we can meet up with what obtains outside the. They have been here before. That was quite a long time ago, 2005, when I came to attend the CORS conference. But for this, the lesson is the training that is the main thing. The knowledge we've acquired so far has been very, very wonderful indeed, really. The process, the things we've benefited is enormous. So we're sure we're going to practice better. We'll come as a group of surgeons from Nigeria, doctors and a few nurses. So we're here. Fathers of talk now, they are in theater working. Yeah.
The range of conditions, gynecological condition that we provide care for laparoscopy, they are quite many. And this will say that any surgical procedure in gynecology can be performed laparoscopically except a cesarean section. But there's one condition that I say it's predominantly ought to be managed laparoscopically, irrespective. So we say there's very little to no role of open surgery to managing the condition we call endometriosis, and there's something that I'm really, really passionate about. Now, there's one challenge in endometriosis is that we still don't know the burden or what we call the prevalence of endometriosis in Africa. But we have a feeling that this condition is so prevalent, and it really doesn't matter whether it's in Central Africa, is in West Africa, or even in South Africa. So the challenge has been there's very little awareness and care that has been provided for patients with endometriosis. And this is something that we are now changing the narrative. How we are changing the narrative is creating awareness, is training other surgeons, is training and forming collaboration, local collaboration and international collaboration. And I'm really proud to say now we have developed collaborations with societies like International Society of Gynecological Endoscopy, society like AAGL, and for the first time, we have developed or we have created a society which we are calling the Pan-African Society of Endometriosis, which will be addressing care and access and treatment for endometriosis, not only in the country but in the continent. And I'm really proud to say that I'm really fortunate to be the Secretary General for this society. But when you look at endometriosis, we really don't find many differences in the care of endometriosis locally here in Kenya and in other setups in Africa. But there's a lot of work that needs to be done, both research and providing awareness and demystifying endometriosis. I'm not really sure if you're going to see the numbers of endometriosis going down. And the reason is because at the moment, we don't know the burden of endometriosis in Africa. For instance, we know that in the Western world, the prevalence of endometriosis is 10%. So 1 out of 10 women will suffer from endometriosis. That data, we don't have it in Africa. And the reason why we don't have this data in Africa is because we have not done our duty as scientists to do enough research for endometriosis. So now what we are really seeing, people are saying the numbers of endometriosis are on the rise. I really don't think that numbers of endometriosis are on the rise. What I can say is that our diagnostic has improved, patients have been empowered, and now we can talk about endometriosis. Remember that endometriosis was a condition that was a taboo to talk about issues surrounding your menstrual health. Young girls who are made to believe or to feel that endometriosis or pain during their menses is something that is normal. But now through awareness and advocacy, women are coming out and saying this is not normal. And this is what is making the public feel that endometriosis is on the rise. Absolutely not. Is that now people are more empowered, we are now able to make diagnosis, and we are able to treat endometriosis. What I really feel that is important is to make diagnosis of endometriosis early enough. So catching endometriosis early enough will help the disease not to advance to a point whereby it's going to affect fertility and significantly affect the quality of life for the patients who are suffering from endometriosis. I get asked a lot, my life with endometriosis, and one thing I really like to say is that I feel that God purposed me to be an endometriosis specialist because this is something that has significantly impacted my life. I now run purely endometriosis clinic, and usually my days are extremely busy. So my day will start as early as 5 o'clock in the morning and could go as late as 11. And this will include seeing patients where clinics get quite busy or performing surgery. Now, just to mention, one surgery for endometriosis can take up to 6 hours, especially if a patient who have bowel endometriosis. So you can find it becomes a very intense program, a very intense schedule for some of us if we have to really see the patient and manage patient with these conditions. My interest is mainly in care for endometriosis, but of interest is that this week we have a very interesting workshop that we are holding, and this workshop we are calling it the end of year camp. And in this end of year camp is whereby we are providing care to patients who require gynecological surgery laparoscopically. And to add to that is we have a number of delegates who have traveled from West Africa to come and join us, and as we learn together and trying to improve and create a sustainable surgical workforce in Africa. Why this is very important to us, especially in minimal invasive surgery, is because we know that minimal invasive surgery usually should benefit patients of low and middle income countries. And why we say this is because when you look at laparoscopy as compared to the traditional open surgery, is that laparoscopy has small incisions, and with the small incision you'll find that there's less pain, so they are going to require less of painkillers. There's less risk of infection, so they are not going to require very expensive and very strong antibiotics. And the stay in the hospital is quite reduced. So for instance, when we perform laparoscopy, patients get to stay in the hospital for a period of about 1 day, as compared to the traditional open surgery where the patient might spend about 3 days in the hospital. So you really find that when we offer laparoscopy, return to work is usually very short. So during this week, we're having a really great experience. Not only are we offering this access to patients through a surgical camp, but we are also collaborating with our colleagues from West Africa, whereby we are training and sharing our experience on how to make minimally invasive surgery accessible in the continent. So when it comes to the care of endometriosis, we say laparoscopy is the gold standard for the treatment of endometriosis. And these surgeries can be very, very difficult and very challenging. What we know about endometriosis is that endometriosis can affect any part of the body. But commonly we see endometriosis affect structures that are around the uterus. So it can affect the ovaries, it can affect the fallopian tubes, and it can also infiltrate the uterus. But in some cases, we have seen where endometriosis is affecting the intestines or the bowels, it's affecting the bladder, and in some cases, it's affecting the diaphragm. Now, luckily enough, is in our setup, and I would really say, I think in the region, we have been able to attain sufficient skill to address all these conditions. And I would really say that we have been the first to offer care for endometriosis, especially the diaphragmatic endometriosis. And we can say currently we are able to offer care for endometriosis of the bowel, where we can even do resection of the bowel, resection of the bladder, and more so resection of the diaphragmatic. So I really feel this is really good news that now patients don't have to go abroad where they used to seek this care outside the country. These services are now available locally. The question is, you really need to be able to get recommendation or referral to an endometriosis specialist who usually have, work with an endometriosis team. An endometriosis team will be the gynecologist who is the team lead. You might need a colorectal surgeon. You might need, cardiothoracic surgeon, you might need a urologist. So this is the team that will comprise to making an endometriosis team. Of very great importance is now we are seeing many patients who have now mental health issues as a result of endometriosis. And now we are saying that we need to have a counselor on board who really understands the effect of endometriosis to mental health.